Today, we have Dr. Edmund Messina of the Michigan Headache Clinic. Dr. Messina?
Hi there. Yes, appreciate you inviting me to be part of this, and we'll be talking about how to communicate with your physician. I'm here in Michigan at the Michigan Headache Clinic. We're in the middle of Michigan, and we treat headaches, and we hear stories from people all the time on how they wish they were taken more seriously by other physicians. I've actually given this a version of this talk to groups of physicians on how better to communicate about headaches to your patients. So this is a kind of interesting area. Bottom line is this. I think what we've seen is a lot of frustrated people. My oldest son and I made a documentary for PBS a few years ago called Life and Migraine. And it was about people expressing how they wish they were taken more seriously. And there were 13 people in the interviews. And the big thing was that they might go to their physician and describe 4 and 5 things that are bothering them, and the physician would zero in on just about everything except headache. It seems like a lot of docs are very uncomfortable in treating it. They tend to have bad experiences, or they don't want to give people addicting drugs, so they're afraid that they give them something they'll become an addict, which of course is ridiculous. But that's the bottom line.
It looks like we have a question from Raymond. His concern is that with an ongoing condition, the doctor cannot just treat based on the impression of the patient in the session. They totally depend on our input to determine the efficacy and safety of their treatment so far. And in planning the next steps, should we keep good records about every headache?
Okay, well, that's a good question about keeping records. I always ask my patients to keep a headache diary. I think most of us who treat headache will ask for a headache diary. Now, a diary, it's only useful if it gives you a good big picture. I think everyone should do it. The bad diaries are the ones where there's so much information that you can't separate a pattern. I usually ask people, I hand out a piece of paper with 31 lines on it. Each one is numbered 1 to 31, and those are the days of the month. And the vertical column is whether you're having a headache, how severe it is, and I use a 5-point scale. I have no idea what a level 9 headache versus a level 8 headache means. I use a 5-point scale. 5 means it's the worst thing, and you're in bed, and you don't care who comes to the door. And it's a functional scale. But I ask them to score that for me and to also tell me, what might have provoked that headache, and they scribble it down. I don't need a lot of detail because I want to be able to look at a single piece of paper and see in a given month where the headaches are occurring. Are they grouped around weekends or around menstrual periods? So I remember one lady years ago, she'd always have them at the end of the month, and it was because she was a business person and she wrote the really, really painful paychecks out on that day, and it stressed her out. So we learn a lot from these schedules. Now, I also suggest, because sleep disorders are so common in the headache world, to also make notes of nights in which you have insomnia, because sometimes there's a correlation there. Definitely worth putting on the headache diary. But a headache diary or headache calendar, it's very useful. The best kind, like at least in my own opinion, is that it be a vertical linear, so you can see exactly how things are going. And the physician looking at that, basically should be able to tell from month to month whether the frequency of headaches is coming down, maybe whether the headaches are pretty much all starting to go away except for the ones around periods or other events that seem to be more stressful. A lot of people have more Monday headaches because of the stress of going back to a workplace that they hate. And a lot of people have weekend headaches, and they don't realize it until they track them on a calendar. What we call a weekend headache might be what we call a letdown headache. We're stressed out through the week, and then you get that one day of rest, and bang, you get a headache, like it's not fair. Now, that's kind of interesting because a lot of people will sleep later on weekends. Teenagers are a perfect example. They'll get up early for school all week long, and then when it comes to be Saturday or Sunday, they'll sleep really late, and they'll wonder why they wake up with headaches on those days. And it's got nothing to do with their blood sugar or hypoglycemia or anything like that. It's because they've interrupted the scheduling system in the brain. The hypothalamus of the brain is in charge of scheduling when you're awake, when you're asleep, when you're hungry. And if you disrupt the rhythm of what those cells are expecting, it kind of disturbs the system, and it's more likely to provoke a headache. But looking at these weekend headaches is very useful. Some people only eat certain foods on weekends. They might go out to a favorite restaurant which maybe has food that's triggering their headaches, or maybe they're in contact, like in a church or something, where they get around a lot of people with perfume, which might trigger their headaches. So a calendar is very important, and I can't stress that enough. Just keep it simple and to the point, because too much detail, which people tend to do, makes it difficult to see the forest for the trees.
Our next question is, are there any blood tests for migraine?
I think most headache clinics, when they first meet a patient, will order some labs. And the labs really aren't explaining the headaches. The only blood test that helps in certain types of headache, and this is not for migraine, would be in older people who develop inflamed arteries around their cranium or behind the eye. And that's called giant cell arteritis or temporal arteritis. These are very dangerous kind of headaches because they indicate that there might be an inflammatory arterial problem which could cause blindness. So we in older people, anyone, and not even older, but anyone over 50 who has a new onset of headaches, we do that blood test. It's called a sedimentation rate or a SED rate. Otherwise, when you meet a new migraine person, the reason we do blood tests is to make sure they haven't been hurting themselves by taking a lot of junk over the counter. You know, excessive amounts of acetaminophen, Tylenol, can be quite toxic to the liver. Drugs like the anti-inflammatories, like any of the anti-arthritis or anti-inflammatory drugs, they could be murder on the kidneys, or even cause slow GI bleeding from the stomach, which a person might not even be aware of, but it might show as a low blood count, like a low hemoglobin. So these don't tell us why you have headaches, not for migraine. Now there are many medical conditions which can cause headaches. For example, if someone has Lyme disease or if someone has other illnesses, but those are not migraine, and those different blood tests are used for those purposes. A lot of times women commonly will ask, well, my hormones must be wrong because I'm having headaches every time I have a period. And there's really no blood test for that either, because it's normal to have periods. And it's normal for migraine people to have migraines during their periods. It doesn't mean it's okay, but the blood test would not help us with that. Hormone levels would not be useful. So I hope that answers the question. So,
our next question comes from Diane. We're having a hard time after a traumatic brain injury. They want to treat for migraine. We believe it's cervicogenic headache and need to rule out that she is having a migraine. How can we do this?
Okay, well, when people have traumatic brain injury, it's never just one thing. I mean, your head is damaged, the neck is involved usually since it's connected to the head. If it's an automobile accident or if it's, anything, your roadside explosion, anything, you have to look at both, and it may be a combination of the two. A traumatic brain injury does damage to the brain itself. It does damage to different nerve cells in the brain, and some of these have to do with modulating pain. Post-traumatic headache is an entity all by itself, and it's not unusual, and sometimes it can go on for months or years. Usually it goes away less time than that. But when people have neck injuries, a chronic neck pain can feed headache. Now, these aren't migraines, though. Now, when we treat post-traumatic headache, we use a lot of overlapping drugs that would normally be used for migraine. Usually, post-traumatic headaches, be it coming from the neck or the head, will respond to the common preventative medications. They could be from the anti-seizure class or the antidepressant class. The abortive drugs like sumatriptan, Imitrex, Maxalt, all of those, they aren't that useful at all in these kinds of headaches unless they suddenly occur episodically. It's a fine line to difference between migraine and post-traumatic headache as far as treating episodically. So if it's one big headache, those drugs wouldn't work, but the preventatives may be very useful. So maybe it's a communication issue, back to the topic here. Maybe the patient should talk to the physician more about what they really believe the diagnosis is. Many people with chronic headaches will have chronic neck pain, be it traumatic or not, and the brain will refer pain to the neck, but the neck is a source of pain. And about 90% of migraine people have some kind of neck involvement before, during, or after a migraine attack. And again, we strongly recommend stretch exercises, home exercises. When they're not really successful, we don't think there's a magic drug for neck pain, but we know physical therapy is extremely helpful. I mean, legitimate physical therapy with a registered physical therapist, someone who understands the anatomy. It's not a treatment for migraine, but it will treat neck pain as it relates to the back of the head. But you've got to, when you have a traumatic head issue and neck pain, you really can't separate them out. You need to treat the whole unit. and find what seems to respond best. Physical therapy is a real common thing to use in these situations. Now, can I come up with the best way to communicate with the physician when you first notice you're having headaches? Okay. Well, this is a good question, and it's relating to our topic here. In order to communicate with the doc about your headaches, they got to realize right off the bat how much this impacts your quality of life. For example, I mean, when you're talking to your doctor about headaches, you know, everybody gets some kind of headache. Everybody is probably experienced some tension-type headache, which is usually no big deal. People with migraines, you know, look at those as kid stuff. Everybody gets tension-type headache. So if you're talking to a doctor who doesn't have headaches themselves and maybe has had some tension-type headaches, when you say, I've got a headache for 3 days, their brain is kind of playing back their own experience and going, well, come on, don't be such a complainer. We all get headaches. Fact is, migraines are nothing like it. So they have to understand what it's doing to you. When you're communicating to your doc about your headaches, mention whether or not it's keeping you from getting to work or getting to school, or whether it's making you not do your normal activities socially or with family. The MIDAS scale, M-I-D-A-S, is a measurement scale developed by Dr. Lipton at Einstein. And I believe there's a MIDAS on the National Headache Foundation website you can actually link into and use. The MIDAS scale will give a number to the impact on your quality of life. Above 20 is very significant. I commonly see 100 and 200 in our new patients. But the MIDAS might be a way for your doc to understand what you're doing. They got to understand the impact on your life and the urgency in which you need a solution. If they understand how severe the headaches are, they might think in terms of what might abort a migraine. They need to understand what a migraine is. Unfortunately, based on recently published studies in the last 2 years, about 50% of migraine people are not even aware that they have migraine. And of people who have migraine who go to their primary care physician about their headaches and who need to be on a preventative medicine, only 7% are being offered a solution. So you got to take it, you know, you got to take the driver's seat here and really make them understand that you need a solution to the individual headache. And if it's going to be treated more than once a week, you better be on some kind of preventative strategy, or you're going to develop medication overuse headache or rebound headache. This is what you have to convey to your doctor. It's really kind of easy when you think about it. If you make a list of what it's done to you in the last few days or in the last few weeks, they may better understand the need to act on these headaches. When you say that my headache puts me to bed, I have to leave work, I have to have someone pick me up because I can't stand bright light, I can't drive, I'm in my room, I'm throwing up in a waste paper basket. You got to make it dramatic. I mean, it has to be truthful but dramatic, so they can see the true impact on what it's doing to you. By the same token, when you're talking to your doctor about medicines that they've given you for your headaches, they got to really understand whether or not they're working for you. Now, here's some ticklish areas too. When a physician is giving a lot of painkillers like Vicodin, hydrocodone, or Percodan, oxycodone, and other very potentially abusable drugs, they're hesitant to give them because they are potentially addicting. And yet they feel pressured to give you something for your headaches. Now, these are not really the treatments of choice for migraine. There are better drugs for those who can take them, and those are the triptans, and there are 5 fast-acting triptans. The brand names of Imitrex, Maxalt, Axert, Relpax, and Frova. What am I forgetting? Zomig, the fast-acting. Frova and Emerge are the slower-acting triptans. They have to realize that these are usable drugs. If they're afraid to use them and it's not clear why, then they should be sending it to a headache specialist to take care of it. As far as preventative medicines, it's important that you let them know about side effects. Now, a lot of times we use antidepressants to treat migraine, to prevent migraine. And the antidepressants are not necessarily being used because we think you're depressed. It's just that the chemistry of migraine overlaps a lot with the chemistry of depression. But now some of the antidepressants can produce side effects which some people are too embarrassed to talk about. Some of the antidepressants can produce lack of sex drive, lack of libido. Sometimes they can prevent a person from having a climax or an orgasm. And these are worth mentioning to your doctor. Don't be embarrassed. I can usually tell when a patient has the problem, because usually the spouse comes in with them to the visit, and I already know this is what we're going to talk about. It's important. And but yeah, you got to let them know what your side effects are, and you got to let them know that the medicine they gave you is working well or not working well, and maybe the dose needs to be adjusted. Or if it's a rescue or abortive drug to kill a headache, if it's not working, they can switch it to a different one. There are many choices. The battle is always with the insurance company, but that's beyond today's topic. But as far as communicating the severity of the headaches, that's the big one.
Thank you, Dr. Messina. Our next question comes from Bob. How effective do you think riboflavin and CoQ10 are for preventative? My neurologist has indicated it's good to take these supplements. How do I convince my primary care physicians that they are useful?
Well, I don't think they're useful, so you got the wrong guy here. The only, it's just, any study showing any kind of improvement with anything, it could be sawdust, it has to give you more than 30% response rate, or it's placebo effect. I wish these things did work. I personally, in my own experience in 30 years of doing this, I've never seen anything like that be much help, at least not to my patient population. Maybe my patients are just more severe because they get sent to me because they're bad. But I don't see them helpful. A big concern I have about supplements is that they're not regulated for purity in this country. The Germans are very careful about that. In the U.S., a drug can be sold in the U.S. with the word supplement on the label, and they're not being held to the Pure Food and Drug Act or any other truth in labeling and anything. They're not held to any standards at all. So there's a chance you could be taking something that's toxic. It's, for example, Butterbur is the only supplement that's been shown to have any value in preventing migraine. It was just published last month in one of our journals. But the problem is getting pure, unadulterated Butterbur, because if it's not pure and properly prepared, it could be carcinogenic. And that's a serious issue. Some of the meds, we hear rumors on the street that sometimes magnesium is helping reduce menstrual migraine in women who have menstrually related headaches. And it may be true. It's just that none of these are overwhelmingly useful, and there's never been any really big successful series on any of these supplements except Butterbur, but I'm afraid to use it because I don't know where to get pure, unadulterated Butterbur. There are papers in our journals that talk about these independent laboratories which grab these supplements and start analyzing them, and they're finding insecticides and lead and mercury, all kinds of stuff in them. Because nobody's watching. There's no inspector. So I just would caution you about these things. They're probably harmless. I'm not convinced that they're very valuable in treating headache.
Our next question comes from Lori. Under the circumstances of having chronic migraine, shouldn't my doctor have referred me to a neurologist or at least scheduled an MRI? How do I ask for this without making the doctor feel like I'm trying to do his job?
Well, it depends on how long you've had the headaches. I mean, not everyone needs an MRI who has migraine. In most referral centers, like my own, we tend to do them just because we're like the fifth person that they've seen, and if it hasn't been done, it bloody whatever should be done. But if someone shows up in a primary care office who has all their life since they were a teenager, intermittent headaches, which have a very typical migraine presentation and typical migraine story, it's not necessarily necessary to scan them, although I tend to, just again, because we're a referral center. If a person needs to be scanned for a headache, we really don't think a CAT scan is a very good idea. It's a 70s test, very impressive in the 1970s, but there's radiation, and when you give dye, which you have to give, otherwise it's a useless test, it just increases the chance for adverse effects. So an MRI is the test of choice, and if a person is not doing well or they have persistent headache or new onset of a headache, and there's a list of reasons called the Terrible 10 of why a scan is necessary. It should be done in a legitimate place. It should be done and read by a certified neuroradiologist. But as far as you're talking your primary into sending it to a specialist, as a specialist, I'm sort of biased in that direction. I think if a primary doc can't get it under control within a couple of tries, they probably, in their own heart, should be realizing that they should send you somewhere. Unfortunately, we see people that someone's been messing around for 1 and 2 and 3 years with various unusual combinations of things and not getting anywhere. It's like, if my car goes clunkety clunk, I want a skilled mechanic to fix it. I don't want to go out there and try it myself. So I think it's reasonable to present this to the primary doc. You should mention your frustration, and being open-minded. Hopefully, they would realize that if you're concerned and your headaches aren't responding, it's probably not a bad idea to send you somewhere. I mean, if you had chest pain that didn't go away, I mean, you bet they would send you to a cardiologist. So I think it's a reasonable request, and it's not like you're trying to, I don't know, undermine the doctor-patient relationship. But remember, as doctors, our job is to be your advocate. Our job is to do what's right for the patient, not to prove that we can fix anything. Our job is to find a solution. If we can't get it within a couple of tries, we need to send on to a place where they where this is what they do. So hopefully that answers that question.
At what point should one see a headache specialist if their primary care physician is not taking their head pain seriously?
Once they realize they're not being taken seriously, and if they can't make it clear to their doc that it's bothering them, then they should just get out there and do it. It's not always easy to find a headache specialist. There, you know, NHF, the National Headache Foundation website, has a listing of them. There are some places where there's no certified specialist. I know there are parts of certain states around the country. I hear from people, and there's nobody in the whole state who's been boarded in headache. I think once you perceive that you're not being taken seriously and you're suffering, and if your physician is not amenable to sending you somewhere, I think most headache clinics would accept self-referred patients. I know we do, and I think most will, because it's a big problem, and it affects the quality of life of so many people. It's not just the patient, it's their family, and it affects everybody. And if you're not getting satisfaction, then I'd move on down the road. A headache specialist is someone who has been able to prove their training or their certification in the treatment of headaches. And the American Board of Medical Specialties does not yet have an actual headache certification, but the Unified Council for Neurologic Subspecialties, UCNS, which is a spinoff of the Academy of Neurology, does have a headache certification in which doctors in training are now able to be certified. People from my generation of doctors who have been treating headache for the last 20, 30 years, we were able to qualify with this board by showing a certain amount of research, certain amount of training, et cetera, and then submitting ourselves to a very grueling board examination. And that's the board that determines a headache specialist, and there are about 280 certified headache specialists in the United States right now, which is not a lot when you consider there are thousands and thousands of doctors. But a headache specialist generally works either in a solo clinic or as part of a university. And headache specialists pretty much, if it's truly a headache clinic, that's pretty much all they do is just see people with headaches. And there are many different kinds of headache, of course. Now, in the headache world, we can't just say, okay, your head hurts, here, take this pill, or just use the vending machine in the waiting room. Headache people are not that simple, and they generally have a lot of things going on. And we need to know about all that. And again, as I swing back to our how to communicate with physician topic, when you're telling your physician, either your headache doc or your primary, about your headaches, you got to not ignore all the other symptoms you might be having. Things relating to stress at home, stress in the workplace, relating to sleep disturbances or anxiety and depression, other symptoms. We need to know if you have palpitations or if you feel like you're going to faint. These are all important things because it makes a difference in medications that we choose. I would rather the patient didn't decide what was relevant. I'd rather I got too much information and let me sort through it. It's always the better way to go because we find all kinds of unusual things. In fact, I remember not long ago a lady came in who was having awfully controlled headaches. She had migraine for years, but the last 10 years they've been so much worse. And it turned out she wasn't getting much sleep at night. So we talked further. People with sleep disturbances, of course, get more headaches. And we talked some more, and I asked her, why can't you sleep? And she said, well, I have to get up every hour. And I asked, why? And she said, well, I have to get up and pee every hour. And I said, well, do you have an infection? What's going on? She goes, nope, I drink a lot of water, and I have to get up every hour and pee. And we talked a little bit more, and it turns out that 10 years ago she was in a car accident, and it damaged the pituitary, which is that big gland in the middle of your brain, middle of your head, which controls the kidneys. It's called the antidiuretic hormone, and she was missing that. So she would pee up to 4 gallons a day, and if she didn't drink 4 gallons of fluid a day, she'd pass out. And again, see, I just needed to know that. I mean, what does urine have to do with headaches? Well, it did in this case. You have to ask, and you have to tell everything. It's very important. Sometimes you have to organize your thoughts and make it sound somewhat so they can understand what you're driving at, but you got to tell about the impact, and you got to tell about all these other things. A big one, which is very commonly overlooked, is sleep apnea. People with headache, any kind of headache disorder, are going to do worse if they have sleep apnea. Now, the classic sleep apnea person is someone who stops breathing at least 5 or at least 10 times per hour in their sleep. And you don't know who they are. If you sleep with somebody who has apnea, you'll notice that they don't breathe, or they'll start to snore really loud, or they'll breathe a lot and then they won't breathe for a while. These people will get up tired in the morning. They don't feel like they've ever had enough sleep. And during the day, they fall asleep all over the place. They'll sit in a meeting and fall asleep. They might fall asleep at the wheel, which is very dangerous. And these people, if the doc knows about the symptom, and hopefully they're sharp enough to recognize it, they're going to suspect at least sleep apnea, obstructive sleep apnea, and send them off for a sleep test. Again, it's all about communicating symptoms. We have people whose headaches are way out of control because they drink 10 or 12 cups of coffee a day. And of course my question is, why do you drink all that coffee? And they'll say, well, I'm so tired I have to drink it. And then of course the questioning leads eventually to a sleep disturbance, which leads to the drug which is causing the headaches. Another thing is when people have really bad back pain or other chronic pain, arthritis and things, they need to tell me about that, because they might be taking a ton of painkillers with these other painful conditions, and these painkillers might be causing the rebound headaches or medication overuse headaches. So a complete story is very important. And a doctor can't see you for 5 minutes and get all this from you. They have to be able to be willing to spend some time with you and ask questions and answer your questions. Anybody who runs you through like a bum, you're not getting the optimal care experience. And you should be a good consumer, and don't settle for that. Another bad situation, which I run into, it seems like people tell me about these things a lot, is when a doc says to the patient, I want you to choose very wisely. You can only ask me 2 questions, and otherwise you have to make another appointment. That's unacceptable. You have to know all about a patient. Anyone who tries to limit you in such a way probably isn't the right person for you to be seeing, especially if you're a headache person, because headache people are not easy. They're complex, and they have a lot of things that play a role. So that would be my idea there. And Chris, is there any other area of topic you'd like me to touch on?
Yes. Right now we have a few questions about primary care providers very quickly handing out medications, including pain-relieving medications. The question is, with so many of the medications indicating side effects for migraines, how do you talk to your doctors about alternative treatment plans?
Well, remember, when you see side effect lists, they may not be realistic at all. If you look up aspirin in the PDR, you might be appalled at how dangerous and scary it is. Or if you look up Tylenol or any of these things, I mean, the side effect lists are not relevant to the true occurrence of these side effects. For example, when a person goes to a pharmacy and you give them a prescription for, I don't know, Elavil or something, an old antidepressant, which is very useful in migraine, they might get a list of side effects that talks about everything from cardiac arrhythmias to 40 pounds of weight gain or whatever. But in fact, that person is taking maybe 10 milligrams of the drug, and it was meant to be used at 200 milligrams. You can't take the side effect list seriously unless you see the percentage of people compared to placebo. Now, this is a good trick. You get your hands on the package insert of the drug, which is usually with the drug that they hand out. I don't mean the marketing gimmick printout that the pharmacy gives you. I mean the actual FDA-approved package insert. You can also see them online. If you type the name of the drug and then prescribing information, like, I don't know, Cymbalta, and then prescribing information, it'll take you to that same document, which is FDA scrutinized. Every word in it has been looked at 50 times. And then you look on that sheet and look around on it, you'll eventually find the clinical trials that led to that drug being approved. Any drug to get on the U.S. market has to have had 2 separate independent American-done clinical trials. And each of these clinical trials has 2 columns, the test group and the placebo group. And you'll see nausea, vomiting, constipation, diarrhea, all these things on some of them. But if you look across the line at the placebo group, those numbers might be identical. So they're meaningless side effects if they happened anyway in the general population. If the flu is coming through an area, we do clinical trials in our clinic too, and if the flu is coming through, everybody coming in tells me that in the last 2 weeks they threw up. I have to write it down. But half of them might not even be on the medicine. But when they do placebo-controlled, double-blind controlled trials like that, you can eliminate the the bias, and then you can tell what's realistic. For the vast majority of these anti-headache drugs, they are safe. you have no idea if the supplements are safe because no one is testing them, and you have no idea what's really in them. So I would say if a doctor is rapidly throwing a painkiller at you, I mean, you have to use your common sense as well. I mean, if you're having like 2 headaches a year and they're devastating and they put you out for the day, and he is offering you just a strong painkiller to take twice a year, well, that's not so bad. If it's being offered to use it once or twice or 5 times a week, well, that is bad, and that's a bad thing. So you have to put it in perspective. Just because a doctor reacts to your headache doesn't mean it's something bad. And of course, we use pharmaceuticals in this day and age. We in the future we'll look back and say, ha, they used to use chemicals. But right now we're kind of stuck with it. And the only legitimate chemicals are ones that have been tested. The pharmaceuticals, I'm not a huge fan of the pharmaceutical industry. Needless to say, I think there's a lot to be fixed there. But I do know that in order to get through the FDA, at least you have to be somewhat good enough to be safe and whatever. And it's all about doses too, you know. I mean, if a drug is known to cause trouble in one dose group, in headache we tend to use doses very different from what the drug was intended to be used for. If it was a drug meant for depression or epilepsy or whatever, we might be using a fraction of what the dose would have been when they did the clinical trial. So it's all individualized, but I wouldn't give up on medicines just because you're reading a bunch of side effects, because if they could put side effects up with the alternative and supplements, you'd have a list just as big. It's just that nobody is bothering to study them.
All right. My headache specialist sees me once every 6 months. How best should I communicate with her? Should I keep a headache diary during that period of time? And what are some suggestions aside from keeping the diary that you can suggest to me to communicate with my headache specialist?
Well, the question is why communicate? If you're communicating to say, I'm doing fine, haha, I'm sure every 6 months would be fine. If you're communicating because the medicines aren't working or you're having side effects or your headaches are out of control, you should be seeing that person. 6 months is a long time in between visits for a headache person. My general rule of thumb is when I first meet somebody, if they're having, when I first meet someone, period, I generally see them in 2 to 3 weeks. Because by then I've got my labs back, I've got the first medication starting to settle in, and I'm going to find out whether it's helping or not. When I have somebody off work because they're devastated by headaches, I might see them weekly or every 2 weeks. If I get things cooking and things are working well, I might see them a month later. If they're still doing well a month later, I might stretch it to 2 months, and then maybe 3 and 4. If I have someone on a daily drug, and certainly if they're using a preventative on any kind of regular basis, I don't let any more than 3 or 4 months go by, and those are on really stable people. 6 months is if someone is not on a daily preventative and uses an occasional rescue drug which works. I generally don't stretch my visits to yearly because things happen. Migraine people are so vulnerable to so many variables. They could be doing great, and all of a sudden they get a bad boss, and everything goes out of control. So we need to see people sooner. And if your communication method with your doctor is simply to tell her that you're having problems, well, then you should be having visits sooner. 6 months is a long time.
What are the most important questions to ask your primary care physician about treatment?
The real important thing is to tell them what your symptoms are. But if they ask you, if they say to you, okay, well, maybe let me word it this way. Let's say they say to you, I'm going to give you drug XYZ. Then the important question is, well, I mean, it depends on what the drug is, but I mean, the important question is, what should I expect? Some medicines are great, but they might make you get a dry mouth for a few weeks before you get used to them, or you might be drowsy in the mornings for a while before you get used to them. You should ask, what do I have to expect here? So expectations are really important. A real good question, and it's about patient expectation when it comes to communicating with your doctor, is they may not know that you expect a rapid response and a quick fix, and they may realize that their meds are going to take a few weeks to starting to work, and maybe 4 to 6 weeks even. It's good that you express your expectations to the doc, and that they express what's a realistic expectation from their perspective. You know, it happens to us sometimes. Someone will call us and say, you know, I've been on this medicine for 2 days now, and I'm still having headaches. Well, yeah, of course you are. It's going to take at least a week or 2 to even reach a steady state in your plasma, in your bloodstream, and then it's got to soak into those nerve cells for a while. And we might say 4 to 6 weeks, we're going to start to see a trend. It's all about expectation. So those are the questions to ask. What should I expect? Are there any side effects I should look for? A lot of docs, you know, they're hesitant to give you too many side effects because they're afraid that you're going to start manufacturing them. And it's true. You know, if you know something's going to happen, you're going to start looking for it. But it's just whether significant side effects. For example, Is this going to make me too sleepy? Can I drive safely on this med if I take it at night? Or will I be too sleepy in the morning to drive to work? Can I taper up on the medicine gradually instead of suddenly going on it? These are all good questions to ask. A good question to ask when they give you an abortive drug in order to kill a migraine. You really should ask, when should I take it? Should I take it at the first time I notice pain, or should I take it when the pain has reached its maximum? And it depends on what the drug is. If the medicine is a triptan, like the Imitrex family of drugs, you generally should take it at first pain. If you take it too early, it'll come and go before it's really being able to be useful. But those are good questions to ask your doctor. The next question is, when will you see me again? If they just say, oh, well, just start this medicine, and I'll see you when I see you. I'll see you when you're in trouble, or call me when you need a refill. That's sloppy medicine, and it's not the way to treat chronic headache. So you should ask those questions. It's, what if, or if let's say there's something about the medicine you don't like. For example, they say to you, well, you might get weight gain. It's useful to know ahead of time, because if you know the drug might increase your appetite, you might be extra on your guard to not surround yourself with tempting foods and stuff in the fridge. If it's a med that you know is going to help you, but it might make you eat more, you just want to, it's good to know ahead of time. Will this affect my appetite? Will it cause me to gain weight? Will this affect my ability to take other medicines that I'm taking? Will this interact with the medicines that I'm already taking? These are good questions. Patients ask me that all the time, and it's a good question. I mean, obviously, I've already thought about that ahead of time, but by telling them, no, it won't interact, I'm reassuring them, too. But we have to, I mean, anyone prescribing a drug better sure as heck know what other medicines you're taking, but you should ask that question. You might say, well, I don't like the idea that this medicine might has a chance of causing hair loss, even if it's rare. I can't take that chance. I'm a news anchor or something. I can't take the chance. What else can you recommend? What choices can you give me? Those are not unreasonable questions to ask. I mean, a physician, if they feel threatened by those questions, well, you should see somebody else. We should have a good reason. Every time we do something with a patient, we should sure as hell have a good reason for why we're doing it, and we should be able to tell the patient why. And the reason might be because it's been written up in such and such journal, or because this is the standard of care, or because in my experience this has been a very useful drug in other patients. But these are answers and these are reasons. And but it's not unreasonable to ask those questions. It's okay to do that.
What are your thoughts on the length of maintenance medications, for example, Topamax, and talking with your physician about long-term side effects?
Okay, well, long-term side effects with something like Topamax, we'd be worrying about kidney stones. Anyone starting Topamax, topiramate is the chemical name, anyone taking it should already be asked ahead of time whether they've had kidney stones. We shouldn't give this drug to people with stones. It doubles or triples your risk of having a kidney stone someday. I've never seen a problem long-term with this drug, and we've been using it since, I don't know, about 14 years maybe now, because we make sure that people absolutely promise they're going to drink 2 liters of fluid a day. More if they sweat a lot by working outdoors. And that's the only long-term thing. It's what's going to happen during pregnancy. If you're planning a pregnancy, just about none of these drugs should be on board, even from the moment of conception. As far as duration of treatment, a general rule of thumb, it depends on how long you've had bad headaches too, but if we start treating somebody for headaches and we got a good plan going and things are working well, and their life changes, it becomes a little less stressful, they retire, they got that divorce they've been needing, whatever, they might not need as much medication over time. And usually, if people are doing great for 3 months in a row, I'll at least talk about the possibility of reducing very gently the preventative strategy. Some people need to be on it for years at a time, and other people weeks or months. Usually months, sometimes years. It's very common. But again, this is my patient population, which are very, very difficult migraine people who have been on just about everything in the world before I meet them. Duration of treatment, it's based on how you're doing and when do you feel, like Clint Eastwood said, feeling lucky. When do you feel like maybe the idea of taking a medicine is more annoying to me than I remember my headaches to be. And whenever you take away a preventative medicine, you do it very, very slowly because you're trying to unmask what is that threshold below which I'm going to get headaches. And you also do it very slowly because you might have some spontaneous headaches popping up anyway, as everyone will, and you don't want to misinterpret that as being caused by stopping the drug. So you do it slowly. And ultimately, our goal in treating headache is to get off the medicine over time and maybe only have the rescue drugs left after a while. It depends on the person.
When seeing multiple physicians, I run across different schools of thought. How do I manage the differences of opinion? For example, one doctor is a big proponent of medication use, and the other one isn't.
Well, it depends on what you're treating. If you're treating epilepsy, I don't think there's two sides to that coin. I mean, either you have seizures or you take your medicines. When it comes to migraine, I don't, you just can't say, there's no such thing as 100% medicine is my only approach or no medicine is my only approach. They're both extremes and neither one is smart. We commonly, again, we use pharmaceutical agents to treat our headaches, but we also alter lifestyle. We give people instructions on how to manage their diet and look for trigger foods. We don't use headache diets, but we tell them to look for certain triggers. We really dig very deeply into the stressors in that person's life, and if they've got a significant amount of stress, we get them referred to counselors, be it marital counselors or personal therapists. If a person has a lot of neck and other pain with their headaches, we make sure that they see someone like a physical therapist. It's not just the medicines that make the migraine better. You need to alter lifestyle. On the other side of the coin, these people that claim that you don't need to give patients anything except kindness and maybe a sprinkle of oregano on their head or something. I don't think that's going to cure too many migraines either. Both extremes are foolish. There has to be a mix. You need to combine lifestyle change, which is very important, but when that's not enough, you need to use medication to prevent. And when it comes to aborting a migraine, sure, you can go hide in a dark room and put ice on your head or put heat on your neck, and you can, like when we treat pregnant people with migraines, we don't use medicines for that, and you can use physical agents like that. It's just those are never as efficient as using an abortive drug. There are times we can't use certain medicines. People with heart disease, we can't use any of the triptans. People that had stroke, we can't use the triptans. So we either manage them with the other kinds of painkillers, or we try to get them into meditation and other things. Not all those things work. The acupuncture has been shown finally to be a little bit better than placebo, and it has a place in some people. But it's not a real big performer, but sometimes when you don't have a lot of meds that a person can tolerate, sometimes that's a useful thing. Yoga is very helpful, stress management. These are all non-medicinal approaches, and any decent headache clinic is going to talk about those approaches in addition to medications. So as far as getting the communication between two different opinions, I guess the question is, why would you be seeing two different people for the same problem, and why don't they talk to each other?
It looks like we've answered all the questions for tonight. Dr. Messina, if you could point people in the right direction as far as any type of resources they could use after a communication with their doctor is not as successful, or just any extra resources that they have available.
Absolutely. Again, I'm a big fan of the National Headache Foundation. I've known you guys. In fact, I met Dr. Diamond when I was in medical school in the 70s, so I know the foundation well, and I really, really like the work that they do. I think that's a good resource right there. There's a lot of sections in the NHF website which answers questions about specific illnesses, specific headaches. Also, I link from my website to other places too. My website's michiganheadache.com. And we have a link in there on who the headache specialists are if you can't get through on the NHF website. The larger medical centers around the country all have informational sites about headache, including like Mayo Clinic or Mass General and those places. There are various support blogs out there, some of which are helpful, some of which are obviously run by people who don't have any medical knowledge. But if you stick with things like NHF or the major medical centers, you're going to hear the same story. The International Headache Society, of which in the U.S., the American Headache Society, are also good resources for finding information on their websites. It's important to read about these things, but try to avoid the "oh, poor me" blogs. Stick with the factual, juried websites that are put together by committees of people that are expert in the area. It's not okay to have headaches. It's not okay to not be treated properly. And you sometimes have to be the one who makes the move. Most migraine people tend to be rather aggressive about their care, and I appreciate that. I think people need to be. You've got to be your own advocate. And once you stick up for yourself, that makes a difference. I want to plug a movie here. There's a movie called Lily's Mom, L-A-L-Y, Lily's Mom, which is about a woman with headache. It's a feature film. I directed it. And it's about a woman who finally spoke up for herself and went and demanded to be treated. And her life changed drastically. It's a story we see all the time. But it's okay to ask questions. And your doctor, I mean, you don't have to be accusatory and throw a bunch of printouts from the internet in their face, but it's presenting an honest question to a physician. They should be interested in answering it in a way that brings you comfort and brings you information. And if they don't, or if they're threatened, or they get mad at you, well then, that's why they make highways, and that's what you should do. I think most docs are really interested in helping their patients, and if they understand, above all, like I said in the very beginning, if they understand how much this really means to you, how much this is really messing up your life, I think they'll be a lot more sympathetic to finding you a solution, either by themselves or by sending you to someone. And I think that really summarizes the whole point of today's talk, was on be your own advocate, and be sure your doc understands the real consequences of your headaches on your life.
All right. I'd like to thank you for joining us tonight, Dr. Messina. That's our session for tonight. Everyone have a good evening. And again, thank you, Dr. Messina, for joining us.
Thank you. Bye-bye.
You're welcome.